Hello, Houston. We were just sitting here reviewing what we're going to talk about today, and kind of in the grand scheme of things, what we've done over the last couple of weeks is to review theories of personality, and we've made you ill, and now in fact we're going to fix you up today. So the central topic today is essentially psychotherapy. Why don't we just jump right in with a definition in terms of what I'm actually talking about here, and that is we're going to define psychotherapy simply as the use of psychological techniques for the treatment of mental disorders or behavioral abnormalities. But there's another more direct way to define that, and that is to define it instead as simply a professional, psychological, helpful relationship or helping relationship. You could use it either way there. But in both cases, it's essentially it achieves about as much as talking to a good friend will do if you have a personal problem. And in some ways, that's kind of the control group against which the efficacy of psychotherapy is compared. That is, how much better is this particular version of psychotherapy, whatever it may be, going to improve you over and above what would happen if you just sat on with a friend and kind of worked through, this is my problem, here's how I'm trying to handle it. But there have been a lot of historical changes in the way in which we deal with psychotherapy, define it and so forth, offer help to one another. The oldest of this is probably the kind of thing that was going on in Salem witch trials way back in as early as 1692. And there are a lot of different ways in which that has been presented over the years. But in essence, as recently as 1692, we were already treating abnormal behavior was viewed, not already, we were still viewing abnormal behavior as essentially some kind of possession, being essentially an untreatable outside force upon us that was viewed as simply evil. There were three events that have altered that view since, progressively, but the alteration has taken place. One of these was the appointment in 1792 of a person by the name of Philippe Pinel as Commissioner of Mental Health in France. And in Paris, where his offices were, his very first act as Commissioner of Mental Health of France, was to go into the prisons in which the mentally ill were kept at that point and unchain them. It was the first kind of move away from the very cruel, if you're possessed, we lock you away and keep you protected from society, treat you in distant facilities and so forth and so on. And he was the first officially to actually unchain the mentally ill and begin to treat them as fellow humans who had particular kinds of problems that he viewed ultimately as, in the long term, as might be fixable or treatable in one way or another. There were then two personalities that really had a kind of a major effect on introducing mental health in this country. One of them was a lady by the name of Dorothea Dix, who spent a lot of time in the late 1800s going through the country, basically campaigning for mental health. She was not herself a mental health worker, but she did a lot politically to move that onto the front burner of the politicos in the country, to make the treatment of the mentally deranged a matter of national priority, trying to make the therapies available in one form or another. And Dorothea Dix played a major role in that latter 1800s. And the other was a gentleman, whoops, I forgot I had a picture of Dorothea there. In addition, the other one was a gentleman by the name of Clifford Beers. In 1908, he essentially had been a soldier in the Civil War, and like many soldiers in war, he had had significant difficulties with it interpersonally, intrapersonally. The primary difficulty that he was faced with is that he was on one side and his brother, an immediate member of his family, was on the other side. So anytime he fired out into the fog and smoke of war, there was ever the possibility that he was actually shooting at his own brother. And the more he thought about that, the more difficulty it caused for him, such that when he got out of the war and afterwards, he kind of thought through it for many years, and eventually he felt moved to write a book called A Mind That Found Itself. And what it basically did was to relate his entire life story, starting from his time in the Civil War, and then he in fact voluntarily submitted himself to a mental health facility, a treatment facility, an asylum as it was called at that point. And much of the book is built around trying to depict what he was subjected to during the course of being in that mental health facility, as it was called at the time. Use of the word health might have been a little bit loose in that time. Maybe we're applying modern terminology to older mental hospitals. But in essence, that book, as much as anything else, and the actions of Dorothea Dick, really combined to Dix, D-I-X, really combined to generate the modern day mental health movement and concerns for the kind of issues that such people are normally dealing with. One other major event, or events I should say, that also contributed were the existence of a significant number of returning vets from both the Second World War in this country and then subsequently Vietnam. Both of these wars, in various ways, created significant difficulty for the soldiers who were involved in fighting those wars. As much as we now kind of look back with the perfect eye of revised history, as if the World War II was a united effort on the part of our country, there was in fact significant debate among the soldiers as to whether we should be in that war and the way in which it was being fought and so forth and so on. Some people advocated, for instance, that yes, Germany's a nasty country, but that's in Europe, that's their problem. And there were, of course, counter-arguments to that on a more national or international scope. But in any case, it wasn't a war that did generate some debate in the country. And the returning veterans from both of those wars, World War II particularly, but also Vietnam, essentially created demands for treatment of vets that came back with various kinds of problems into the mental health facility. And that facility at the end of World War II simply was not ready to treat those people. And that was one of the things that advanced the services offered by the Veterans Administration. So the VA, in combination with the returning vets from both wars, really created a significant demand for mental health services, and it was those two wars really that kind of brought the whole issue to a focal point where modern day psychotherapy is offered on a broad scale for people with various kinds of disorders, which leads then immediately to a related kind of problem or question, and that is essentially, okay, so who can practice psychotherapy or offer these kind of professional helping relationships? And there turn out to be a large array of different people who can do so, one of which most prominently are one group involves what are called clinical psychologists. These are people who, through their educational experience, have essentially achieved a PhD in psychology and 1 year of supervised internship in a mental hospital or clinic setting of some sort, that is supervised administration of psychotherapeutic principles in various ways. And so they use psychological principles in clinical psychology. Another broad class that can also be mentioned here would be counseling psychologists. The only real difference between these two is the fact that in both cases they have a PhD, that is 4 or 5 years of graduate training and a 1-year supervised internship. The primary difference is not the use of psychological principles, which they both do, but rather the severity of the disorders of the people whom they're treating. So in essence, those who are clinical psychologists tend to deal with those with more serious, either psychotic or generally called neurotic or anxiety-based disorders, whereas counseling psychologists tend to deal with people like you and me, normal people with everyday lives who happen to have various forms of personal difficulties and need for help in sorting them out. And those are more likely to be the target of the patients of counseling psychologists. But there are some other arrangements that have recently been created that are also rather interesting and also would involve people who can offer you help in various ways. One of these, and somewhat controversial, is a doctor of psychology, what's also called a PsyD degree. And that is whereas clinical and counseling psychologists have a PhD, which is fundamentally a research-based degree, a doctor of psychology holds a PsyD, P-S-Y-D degree. The difference is basically the absence of a research-based dissertation. The training is essentially similar in terms of length and severity or depth of training that's involved. But the PsyD is basically educated in terms of a lot more time spent in therapeutic situations, not themselves subject to therapy, but rather in administering therapy. And so they're in supervised positions of offering psychological help for a longer period of time. The trade-off is less time in research, more time in actually application of psychological principles. Another group in this general area would be psychoanalysts. Among the different types I'm going to talk about, this is the only approach that is uniquely tied to a particular theoretical perspective, that is Freud's. We'll get into that a little bit, we'll come back to this a little bit later. But a psychiatrist is oftentimes an MD, traditionally, an MD who has had a residency in a mental health or clinic setting. Sometimes they simply go on to pursue a PhD. And that's the single distinction between the single distinction that's represented here is simply that this is the only approach that I'm going to label of among 7 or 8 or 9 I'm going to talk about that is tied to a specific theoretical perspective. More generally, in this general area, we might have a psychiatrist, which is essentially someone who's got an MD plus a residency in a mental health. I misspoke a minute ago. The psychoanalyst is an MD or a PhD who has extensive training in theoretical therapeutic practice specifically related to Freud's or extensions of Freud's psychoanalysis. It was only in describing the psychiatrist that I meant to say that this is an MD and a residency in a mental health institution. That is the correct representation of the traditional training of a psychiatrist. So let me not confuse you. Psychoanalyst is the one specifically related to Freud, and that such a holder of that label may be either a PhD or an MD. A psychiatrist is traditionally an MD by training with extra experience in mental health or clinic settings, using psychological principles, but may also prescribe drugs and or operate. Among the different groups I talk about here, other than an MD-based psychoanalyst, this is the only group that will actually use drugs and operations to actually correct various kinds of mental disorders, although that's changing. The government has increasingly come to realize that there's nothing magical about having an MD as opposed to a PhD that doesn't allow you to prescribe drugs, and therefore there is a general movement toward allowing psychologists with specific or sufficient physiological training to go ahead and prescribe drugs. The holdup previously was kind of intriguing because essentially you had PhDs who had developed the drugs unable to prescribe them. And they finally came to realize the lunacy of that kind of an approach, and therefore PhDs are also prescribers of drugs under certain kinds of conditions. In addition, there are some others we could talk about. One of these would be a psychiatric nurse, which is essentially someone with an RN with specialized training in treatment of mental patients. Such people are typically in a supervised role. That is, they are serving a vital function in the treatment of mental disorder, but they're under with an RN. They are typically in a supervised position. The same would also be true of those with a master's in social work, an MSW as it's called. Such graduates who have supervised training in clinical and or social service agencies nonetheless can serve a vital role in solving various kinds of mental disorders. Beyond that, we've got various kinds of more specialized occupational therapists. People with this kind of a degree will typically have simply a bachelor's of either arts or science, plus an internship in working especially with people like the physically handicapped. That can also in some cases lap over into the offering of psychologically helpful techniques. And the final one, set in the center but in some ways the least trained, is someone specifically with a Bachelor of Arts, but in various cases, this role can even be played by somebody who has not yet achieved a bachelor's degree. Because in this case, what is normally emphasized for somebody who is a, quote, paraprofessional is essentially the competence of the individual. There's limited professional training behind a paraprofessional, and they tend, of course, because of that, to work directly under supervision. But this would be the kind of person who might, for instance, man people a crisis hotline as one example of where you might find a paraprofessional. It's an alternative approach, but the goal there is basically to kind of catch at the outset, give people essentially immediate help. If you have a crisis and call a psychological crisis hotline, what you're really doing is seeking help because the problem has reached the point where you've acknowledged, yeah, I've got a problem. And if you call at 3 in the morning to get help to get yourself through to the next morning, and thus a more formal form of therapy, a crisis hotline would be a place that you might call, and a paraprofessional is someone whom you would typically talk with there. If you've ever seen a news report out of those centers, typically the people who are on the line there have a huge array of books in front of them, and they're using a stepped interview where they have strategies with which to kind of calm you down and then ask a series of general questions in terms of, what are you, your response basically dictates where they go in terms of advice, because they're kind of, I forget what they call it, a branching interview. That's the word I'm looking for. They give you essentially, they've got a script that creates essentially a branching interview, so that eventually, starting from high all the way down through what's your problem, what's bothering you, they will eventually get to the point across that large array of books of recommending a particular type of individual that you go to, a randomly selected therapist, a community mental health center, a wide array of different possibilities. But that's the role of the paraprofessional, essentially provide the short-term link between you've got a crisis and here's somebody who can help you. In turn, then, if we look at this, and the one other thing I want to talk about is that it reasonably developed in the last quarter century or so. Another kind of approach that sometimes is utilized is a team approach, where what may happen is that you'll find in a given practice a counseling psychologist, a PsyD, a psychiatrist, and a psychiatric nurse may in fact combine as an office complex group of people clustered in an office, because the advantage of doing that is that problems can be treated in various kinds of ways. If you've got a specific, personal, medically driven problem, a psychiatrist is probably your best bet in that situation. But in many other cases, it may just be the environment that you're living in. There are a lot of different potential causes for these disorders, as we kind of summarized in looking at the psychopathology of bad behavior sometime back in the course here. And so the team approach is a kind of a creative way to respond to that, recognize that there are different causes, and thus there may also be different solutions that are appropriate. But if we kind of step back and look at what we're dealing with, there are a number of different ways to model or identify the various forms of abnormal behavior that we find. These models of abnormal behavior fundamentally are divided into two different underlying assumptions. One of them involves the assumption of internal causes, that is, that the problems reside within us in one way or another. And one of the common elements here, one of the common forms, is what's called a medical model. The leading view among these internal causes simply assumes that the predisposing conditions in any of us are internal. There is a specific identifiable internal cause of your personal difficulty, and the therapy in that case essentially involves identifying the cause and then essentially treating it, typically in terms of with medicine or rest or something like that. But in this case, the view of the behavior disorder is as analogous to a disease. That is, you have a specific internal cause of the abnormal behavior that you're manifesting at a given time. Related to this is another approach, and that is essentially the psychodynamic model of disorder, and that would essentially be Freud's view, or theories more or less directly extended from Freud's, developed from Freud's. And Freud's view was essentially that the source of the difficulty that you and I have when we have behavioral disorders is unconscious. We often are not aware of it, according to Freud, but it does generate a great deal of conflict in our life. And in this case, the treatment in terms of pure psychoanalysis is essentially leading you toward achievement of insight, coming to realize what the source of the difficulty is. We'll get back to that a little bit later. But the medical and the psychodynamic models both operate under the assumption that there is an internal cause for the various mental disorders that we may exhibit, or behavioral disorders that we may exhibit in various forms. There's another form. In addition to the medical or the internal causes, we also have those, there's one other thing I meant to drop in here, and that is the thought that in this kind of a treatment, that is in the medical model, typically the therapist plays a dominant role in the relationship that develops between the person seeking help and he or she who is offering the help. So in this case, the therapist is dominant. On the other hand, there is another approach to the treatment of disorder that we may in fact involve, and that is essentially the assumption of external causes. Other models adopt the idea that the causes of our disorders are in fact external to our body. And that would introduce models such as, for instance, psychological or behavioral models of disorder. This is without a doubt the leading view among these models of abnormal behavior in one way or another. It assumes in this case that the abnormality is caused by inappropriate learning, which leads to behaving incorrectly in a given situation. The therapy basically alters the reinforcements that you're subject to, and thus it is hoped, it is assumed, that'll change the ill behavior that you have learned in one way or another, and it leads to behaving incorrectly until you come to be controlled by or responsive to the more positive kind of reinforcers. So therapy in that case essentially just involves altering the reinforcers to which you're responding, so as to alter your behavior in some predetermined way. So in this case, what they're arguing, and there is some argument between those that assume an internal as opposed to an external model. Those endorsing the internal or medical model are arguing with the behaviors that essentially you're treating a symptom rather than a cause. And therefore the idea is that if you come in with a case of terminal nail biting, what the external modelers say is that's the problem. You constantly bite your nails and you're seeking help for it. So we will give you a strategy by which to get you to stop biting your nails. So if you follow that logic, the assumption is that the external behavior is the problem. And that's why it's thought of as an external model of abnormal behavior. You've learned an inappropriate behavior like biting fingernails, and you seek help to get that fixed. Well, of course, the internal modelers are crawling up the wall with that assumption, because they're going to be arguing that, well, the nail biting is caused by some deep-seated internal, potentially unconscious conflict, depending on which theory you endorse. But it is a case that they're kind of at each other's intellectual throats, because there is, in some ways, there's no way to justify an external model of behavior in terms of the underlying tenets of the internal model believers. They simply think that, you and I ooze symptoms, but they always come from the inside. The external modelers are arguing that no, it's the behavior itself that is the problem, and we can offer ways to alter that. We'll also put under this model the humanistic and existentialist therapies, which we'll get to here a little bit later. But this assumes the idea that self-perception and choices based on those perceptions may be the source of your difficulty, and that those are the most important things to look at. So we treat, essentially, in this case, according to this model, by essentially altering your view of your own self-worth. In that case, build the value that you attach to yourself, and that theoretically will impact the way in which you respond to the various reinforcers that life offers in this situation. Finally, then, we can also talk about cognitive models of abnormal behavior, and these basically are also based on an assumption of external factors that lead to in some ways this bridges the gap a little bit as a cognitive model. Cognition is implicitly internal, and yet the causes to which we're responding in this developed self-image is certainly external in the way in which it's formed. So we kind of cover the waterfront in terms of the heavily internal, the heavily external, and cognitive kind of bridging the gap somewhere in the middle, as we'll talk about here a little bit later. And in this case, it should be indicated that the client, him or herself, is typically dominant. That is, in the external models of behavior that are utilized, the client is essentially dominant. And in fact, to indicate the difference in the shifting basis of treatment, you can see it even in the words that are used, because a psychoanalyst will talk about a patient. That is, they're mimicking specifically a doctor-patient relationship, whereas in this form of therapy, you're talking about a therapist and a client. That is, someone who's self-recognized they've got a problem and goes to a therapist seeking the strategies with which to cure it. But such therapies traditionally, as we'll see, are quite short. They'll last 10 or 12 weeks, 10 or 12 sessions. You're given the skills with which to correct the problem, and then it's up to you. I mean, it's your life. If you want to get rid of the symptoms, deal with them in terms of the strategies that the behaviorists give to you. But it's a very different form of therapy that's involved, and really its success is not up to the therapist, it's up to you. It's up to the client. And that's the reason for the fundamental difference in the medical model and those related kinds of therapies being therapist dominated, and the external models being client dominated in terms of the success that they ultimately experience. And this in turn leads to the overall question of, okay, what are we talking about when we're dealing with this kind of therapeutic relationship? And in essence, the Swin, back in 1975, developed a really very nice model of what constitutes mental health. And what's listed here are simply the various behaviors that somebody who is mentally healthy will exhibit in a traditional situation. So in some ways, when you start therapy in any of the different models you're using, this kind of behavioral front is the goal. Essentially, what you want is somebody who is effective in dealing with the problems that life throws at any of us in the course of going through it, experiencing it. The second is that we're efficient, that we come to recognize what the disorders or difficulties are and forming strategies with which to handle the problems to keep ourselves on the straight and narrow in terms of effective behavior. That the strategies that we develop are appropriate. I'll have a kind of a funny example of an inappropriate strategy here just a little bit later. But we're shaping ourselves toward, or those who are mentally healthy have a series of effective and appropriate strategies that are on target and work to keep us, essentially happy and functioning. We're flexible. We're able to, any given set of rules only works in a given environment. And so as the environment changes, the rules you're going to have to respond to also tend to change. But we have that adaptability kind of built into us. And all of the things being considered, if we get into a situation where our rules, in quotes, don't work, we profit from experience. We come to recognize, whatever the important elements in that situation are, and we learn to react to them and differ the way in which we deal with it. So we do profit. We gain experience in handling ourselves. We generate additional interpersonal skills. Most of us are always working on that in various ways, how to interact with people to maximize the return to them and the benefit to us from that interaction. And what comes out of that is a sense of self-security. Those who are mentally healthy have a pretty good knowledge of who they are, what their strengths are, what their weaknesses are. Ask anybody and they will tell you on the continuum from introvert to extrovert, they will position themselves somewhere along that. And among other things, you come to realize that certain people are introverts in given situations, but extroverts in other situations. So that as the environment changes, how you react to it may also change. But that's kind of the model that we're working toward of effective behavior in this particular situation. And that leads us then into looking at the various forms in which psychotherapy can be offered. And there are three broad labels that can be applied here. One of them are various physical therapies, which we'll be looking at, such as those that involve shock or drugs to achieve the shock, or even psychosurgery, which we'll also talk about briefly. But those are considered to be physical therapies for a mental problem. Secondly, we have the talking therapies that involve traditionally things like psychoanalysis, but even client-centered therapies like Carl Rogers' approach are still fundamentally talking forms of offering therapeutic help. And then finally, there are the learning-based or reinforcement or behavioral therapies that can also be involved, where behavior modification becomes one of the fundamental skills on which this is based, or approaches on which this is based. So that's the order in which we're going to cover the topics, starting first of all with physical therapies. And this can take a variety of different approaches, but it certainly is assuming an internal cause of the disorder. That is one of the key elements there, is that it tends to involve the most extreme methods that we'll be talking about here through the day today. This form of therapy tends to be reserved for the most severe forms of disorder, such as psychoses, certain forms of psychoses, and it's utilized primarily by psychiatrists, although some work now involves also clinical psychologists in this particular approach. Shock is the key thing that is involved here, or a key thing that is actually involved here. And it actually benefited originally from the work of Ugo Cerletti. I knew I was going to have trouble with that name, but it's Cerletti. He was a psychiatrist in Italy, particularly impactful during the 1920s and the 1930s, and it was he who first, through a kind of a bizarre series of observations of the slaughtering of cattle for the purposes of being part of the human food chain, he noticed that what the slaughterers of cattle tended to use was shock, which basically would quiet the animals in such a way that they could ultimately meet their own demise. But it was in April of 1938 that, in collaboration with Lucio Bini, B-I-N-I, that Cerletti was the first to offer shock as a potential form of in one sense, getting people's attention, but also he noted that one of the after effects tended to be when you had the proper voltage and the proper amount of surging of current through the head, that what you could do is take people who were otherwise quite unsettled, quite hyperactive, and by shocking them, bring them back to essentially coherence and rationality. And this form of therapy, that particular observation, took a while to really fit into the way psychologists normally deal with helping people alter their behavior. But in essence, the shock therapies, all of which I'm going to talk about here, are in one sense a means to an end. They are not an end in and of themselves. So, for instance, the shock therapy that Cerletti originally argued for, or eventually the various forms of electrotherapy that he was advocating for, were thought oftentimes to, yes, shock the person, but more generally in the period of lucidity, which that shock tends to lead to as an after effect, what it does is to increase the ability of those people to be responsive to various forms of talking therapy. So in essence, with what Ugo Cerletti believed was essentially that convulsions are essentially incompatible with schizophrenia and other forms of major disorders. And so having noted the activity in slaughterhouses and the lack of activity that shock produced in cattle, basically he ended up proposing to use the shocking to control more serious forms of disorders. And yes, it produced convulsions, but one of the after effects of that was the period of quiet and increased responsiveness to various forms of, for instance, talking therapy. So in that sense, it became really a means to an end. Typical treatment in Cerletti's original technique was essentially one shock administered perhaps 3 times a week for up to 10 sessions, usually either on one side of the brain or essentially across from side to side. Electrodes were placed on the temporal either bilaterally or in some cases unilaterally, depending on where he thought the particular problem was. And patients for this form, because it is so jarring, so severe, were often given relaxants, muscle relaxants, so that because otherwise one of the problems you face is that you and I have within our body bones that will withstand maximum activity in a given direction. What they're not designed to withstand is if the muscles that are trying to pull your arm in are at the same time being countered by the muscles that you normally use to extend it. If both of them are contracting simultaneously, you can break a bone. I mean, the bones are strong, yes, but they're only designed for supporting activity in one or the other direction at any given time. And being aware of that, one of the things that he did was to, because he was ultimately acknowledging that yes, it tends to produce convulsions, but what you had to do then was to essentially prepare the body for that and get them muscle-wise relaxed before actually applying the shock. Memory loss tends to follow for recent events in that kind of a situation, and it seems to recover for most and seems near total for others in having gone through the shock experience. Nobody quite knows why shock has the effect that it does, but it has been a demonstrated effect for almost 2/3 of a century now. A related fairly severe process is not chemotherapy, but psychosurgery. I'll get back to that in a minute. I was kind of shocked by that title because I wasn't quite yet ready to talk about chemotherapy, which is what I did really want to talk about. And that is that essentially since the mid-1950s, drugs, well, in fact, to show you the kind of cycle that we went through, the reason shock therapy was introduced in the 30s, late 30s and 40s, and it became successful was because prior to that, things like insulin and metrazole had been used as the primary causes of the muscle tensioning and the convulsions that followed. And certainly as a diabetic, I can convince you quite easily that a serious insulin reaction, which I haven't gone into very often, but it does typically involve considerable muscle contractions, often described as convulsions. I only know of 2 times in my life when I've been that severely disordered. Luckily, in one of the cases, I was in a diabetic camp, so help was immediately available. In the other case, it involved somebody calling for medical help to get me to a hospital. But that's a severe disorder. That also shows you the problem with a significant application of something like insulin, because in my case, it resulted from an unintended overinjection of insulin. But the effect is quite possessing of the muscles in the body, and it's the recovery from that is the quiet period following it that in fact is the reason the therapy is supported. And certainly as a diabetic, given that I do occasionally go into insulin reactions, I can certainly confirm for you that I will get more done in the hour following an insulin reaction than I can in half a day of steady work. you're just, I don't know how to describe it, but it's essentially as you're coming out of it, as your blood sugar level is coming back up into the normal range, you come through a state of very significant cognitive astuteness. You're just alert. Everything's snapping. It's going correctly. It's kind of like you dream of waking up every day. I'm going to get this, that, and that, and so forth done. Coming out of an insulin reaction is exactly that way. You're ready. And in fact, you're responsive and things just happen very smoothly over the next hour or two. Very tempting to put yourself into an insulin reaction, I guess, if that's the result. But in fact, there is that period of quiet productivity afterwards, which really is the reason shock therapy was really even originally proposed and utilized. It's taken other forms, however. Progress often results in this kind of, in chemotherapy, from better knowledge of biochemistry and in brain disorders, what the particular chemical disorders are and how to counter them with injected drugs and so forth. And the result has been the development of various new kinds of drugs for therapy. Fats Domino had a song in the 1950s called My Blue Heaven, and to show the tie between therapy and the real world, that is now the street name for 10 milligram dosages of Valium, is essentially Blue Heaven, an anti-anxiety drug that we'll be talking about here shortly. And so essentially chemotherapy is one of the forms of physical therapy that we can use. This even moves over into narcoanalysis, which is using sleep in one way, induced sleep as a potential form of help. Narcotic applied drugs in that particular case. In addition, we can talk about antipsychotic drugs. These would include things like phenothiazine, also called thorazine. That's one of the technical or commercial products that's available. Clozapine, also called Clozaril. This latter is especially effective for those with severe schizophrenia as a chemical treatment for it. It's frequently used in treating patients with schizophrenia. It has a variety of predictable effects, one of which is reduced agitation or jumpiness, reduced delusions, reduced tendency toward hallucination, and so forth. And the mode of action seems to be that what it's doing is blocking dopamine receptors in the brain. The next one that we'll talk about then are the anti-anxiety drugs or minor tranquilizers. These would include drugs like Valium, Librium, Serax, and Xanax. Those are some of the more common drugs used for as minor tranquilizers. They're most frequently used, that is, to treat complaints of generalized anxiety, panic attacks under certain conditions, and sometimes insomnia, as in sleeping pills. That is, essentially, those can be handled by minimized, reduced in intensity by anti-anxiety drugs. Valium depresses CNS, central nervous system activity, which slows things like heart rate, respiration rate, and feelings of nervousness and tension, which can build up in people otherwise. Hence, it is described as essentially anti-anxiety drugs. People often adapt to or tolerate small doses of the drugs, and thus larger doses tend to kind of be incremented into the therapy. And of course, one of the problems is that if the drug dose gets too high, it starts causing side effects which may not be desirable. And that leads to another thing that has been analyzed, and that is the withdrawal effects of what happens if you cut somebody off from various anti-anxiety drugs. Common withdrawal symptoms would include things like sweating, tremulousness, insomnia, and rapid heartbeat, none of which are necessarily particularly desirable in this situation. So these various forms of chemotherapies do have their associated side effects, and again should be noted as a means to an end, typically not an end in and of themselves. They are not simply applied with the therapist then dusting his or her hands, assuming the problem has been solved. This may increase your sensitivity to other forms of psychotherapy. But in and of itself, chemotherapy is not typically the ultimate answer. This also includes things like antidepressants, which can be used, or major tranquilizers. That would include things like phenothiazines, such as thorazine, and I've already talked about this. Where do my arrows go back and forth here? So in essence, these are the antidepressants that are involved here, leading to essentially, sorry, let me speak again. The antidepressants that are involved here essentially are given to those with severe depression, where depression is the key element in that situation. The mode of action here is essentially increasing the amounts of noradrenaline and serotonin that are available in the brain. That's the net effect of applying various kinds of antidepressants. I misspoke when talking about the phenothiazines there just a minute ago. That's an antipsychotic drug, which we talked about earlier. No wonder the notes sounded familiar in going through it. But the antidepressants are used when you have severe depression and a need to get that kind of thing fixed. And the mode of action is basically increasing the noradrenaline and serotonin that's available to your central nervous system. The effects that are achieved by antidepressants are essentially to reduce physical effects of depression, increase your general activity level, reduce eating disturbances and sleeping disturbances as two of the major effects of adding an antidepressant to someone's system. And as a result of that, the patients again become more receptive to various forms of psychotherapy because that will address then the underlying cause of the cognitive or social aspects of depression. It's a good illustration of the fact that, as I was saying leading into it, that the drug therapies are a means to an end. They are not an end in and of itself. Perhaps the most severe of these various forms of disorders can be, let me back up here a minute because I've skipped around in my notes. That's the problem with having rearranged and then not totally altered the notes that I'm talking with here. Give me just a second to find my place. Okay, let me bounce ahead here and look at well, we've talked about both the benefits and the actions and the drawbacks across each of those different types of disorders that I did want to mention to you. Psychosurgery, that's the one that I was expecting to pop up next. And this has also a long history in the treatment of mental disorders, and that is essentially, it arrived in the form of the ever popular frontal lobotomy, which came out of the work originally of Antonio Moniz, who was a Portuguese neurologist who in the 1930s essentially brought prefrontal lobotomy to the U.S. Okay, what you use in that case for performing a prefrontal lobotomy is essentially a pick-like instrument, which is basically used to sever the nerve connections between the prefrontal lobes, those in the very front of the frontal lobe, and the thalamus. And the net effect there, the typical effect is to produce what is called emotional flattening, where somebody may have been all over the map, hyperactive in one case, very quiescent in other cases. The net result is you kind of bring all of those symptoms to mid-ground, and they just don't get excited about anything, and that is what's called essentially emotional flattening. There's no hyper in anything you do in that kind of a situation. So the typical effect is a reduction of agitation, of aggression, and thus of accompanying violence. The difficulty is that there are some side effects to frontal lobotomy, prefrontal lobotomy, and that includes hyperactivity and distractibility, impaired learning ability, which may happen in certain situations, overeating, apathy and withdrawal, called emotional flattening, as we were talking about it, seizures, reduced creativity, and sometimes, in extreme cases, death. Not often, because of the experience we now have in using this kind of a thing. But essentially, psychosurgery is in some ways the therapy of last resort among the various types that we've talked about there. So let's then, in fact, move into the talking therapies as a second general class of therapy that I want to talk about here, and that is essentially that it's essentially a group of therapies that are endorsing the medical model. That is, that's the underlying premise in psychoanalysis. And basically what you do is to assume that the therapy in pure psychoanalytic form is assumed to take significant amounts of time. That is, we're talking not just weeks, but months and indeed years in certain situations in talking through the disorders that somebody may feel or the disordered views that they may possess in a given situation. And in this case, the therapist is essentially viewed as a source or an identifier of the solution and the internal cause. So he or she has two different purposes. One is to identify the specific behavioral pressure within you that you feel subjected to, and then wending away from that to a better balanced life. And it emphasizes essentially the patient-therapeutic interaction, therapist interaction, I should say, between you and the person giving you help in psychoanalytic form. And the other factor is simply talking. The underlying goal here is a process called, essentially what you're searching for is the blocks that you may be experiencing, things that are impeding you from being able to enjoy a full and enriched and active kind of life in this situation. And what you're seeking therapeutically is to create what is called a catharsis, or a release of emotional energy. And that's exactly the way it's defined, is essentially the release of emotional tension by working through, that is, talking through or even reliving one's basic sources of frustrations. The movie presentations of this, even in documentaries, tend to be a bit overanalyzed or overacted, I guess is the better way to say it in this situation. But for the general, one of the general features of the psychodynamic models is the idea that you're going to lead the patient toward a catharsis, which is a sudden release, perhaps brought about by realization of exactly the nature of the problem that you're having, whether it be your mother or your reaction to your sister in any situation where she's there, or whatever it happens to be. But the psychoanalysis per se essentially assumes that adult emotional difficulties, if you want to call them that, are caused by unconscious traumatic memories. That's the driving force in this particular situation. And essentially what's involved there is a search for the blocks, for what those blocks are in any given situation, and the blocks that you are carrying or experiencing to normal development. It's standing between you and progression toward a normal adult life in that kind of a situation. The therapy as it is traditionally designed does feature a number of very specific elements, and I'm going to show you a very famous photograph here in a minute. But there are 5 general elements that are factored into the traditional offering of psychoanalysis. The first of these is a couch. And the traditional orientation of that is that the patient is in a reclined position, that is a relaxed but still alert position. That is, they're not laying out completely flat. The head is up a bit, and that's deliberate. That is, the positioning in that form is basically not to encourage them to go to sleep, but rather to remove bodily cares and start worrying about the behavioral difficulties that they may be carrying around within them at a given time. In order to facilitate that, the therapist is there, but is not typically positioned, as you can see, in the sight, line of sight of the patient in that situation. And that's deliberate, because the focal point of psychoanalysis is not the therapist, it is the patient. Even though the psychotherapist does play a very active role in that, because the interaction is ultimately the key element of what's involved there. This is the actual couch on which psychoanalysis was originally developed. Or next to which, I should say. I wish the picture was pulled back a little bit further, because Freud's original sitting chair is just to the left, just out of the photograph. I don't know whether I looked at that before and I couldn't tell, but I don't think that black line over here is the leg of his chair, because he was sitting in a more comfortable easy chair in the traditional film or traditional studio presentation, but that is indicative of the way in which the patient was in fact reclining, but in fact not flat out and encouraged to go to sleep in any given situation. But that is Freud's actual couch, next to which psychoanalysis was developed. I guess that's the better way to state it. The second element that is encouraged by the therapist is essentially what is called free association. That is, the patient is encouraged to talk regarding whatever comes to mind. And free association literally means essentially unstructured verbiage or thinking. If you want to think about that, you're encouraged to output whatever comes to mind. And the idea would be, from the stand-back version of the model that he's using, essentially that unconscious urges will out themselves. That is, if a topic is necessary to be talked about, by encouraging the patient to engage in free association, they will eventually position themselves to talk or mention specifically the elements, the things that are causing them difficulty. So it's the pattern of what is, and more importantly, what is not talked about, that is being watched and analyzed by the analyst. So in encouraging you to think about it for a second. If you're, for instance, supposing when you go into psychoanalysis, if you're living in a family situation, that is, you've got a brother, a sister, you, and 2 parents at the dining room supper table, and each day when the therapist comes in, or when you come into the therapist and the therapist starts the session, you talk about your brother this, your brother that, you talk about your mother this, your mother that, your father this and that, and your mother, father, and brother this, that, and the other thing, but you never mention your sister. Essentially, one of the advantages of free association for the observing psychoanalyst is that they can begin to take they can develop a cognitive map of the areas that you do talk about. And in some cases in that map, it may be as obvious as the model I've just suggested, where you've got sis over here, whom you never talk about. You know, encouraged to free associate about family activities, you'll talk about anything but not her, not anything involving her. That suggests to the therapist that she is the source of the difficulty, that something about her or her behaviors is what's really giving you trouble. So the idea of free association is that the topics that you do raise, to a certain extent, in their totality, define the things that you don't raise. A little bit hard to understand that, but essentially, given enough things that you talk about, there are certain things that you don't talk about. And that's the value of free association as an element. A third thing that is involved here, and again, that's really used as a road to the unconscious, is dream content. The patient is often asked to relate, and in fact is encouraged to keep a record of what in fact he or she is dreaming about over the course of psychoanalysis. And the theory is that what that's going to do is allow the therapist to gain insight into your motives, into the things that are driving you in a given situation. And what Freud is really interested in there are two different kinds of things relative to dream content itself. The one is the manifest content, that is whatever you actually recall about the dreams that you have. But he or she is also interested in what is called latent dream content. And what that was interpreted as, according to Freud, is essentially the symbolic meaning of the dreams that you have. And so the reason you're encouraged to recite those is simply to give the psychiatrist, a psychoanalyst, information about what it is that what's on your mind when you're asleep. This in turn will lead to another element of essentially, I described it earlier as in a slightly different way, but resistance is essentially an important element of that free association, as I said, simply because it's an important element of information. The things you don't talk about are in some ways just as revealing as those that you do choose to talk about. But resistance also shows up in a number of other ways. If you miss an appointment, the psychoanalyst is going to make note of that in your record, maybe so you can be billed, but also more importantly to keep track of the story that you're telling. Because what that may identify for the psychoanalyst is the idea that if in fact you miss an appointment, what that may be telling him or her is that if they go back to look at their notes, they may pay particular attention to what was the fundamental substance of what we were talking about last week, because somehow that has pressured somebody to forget the appointment that was scheduled for this week on Wednesday at whatever time, or Thursday afternoon, or whenever it happens to be. And so missing an appointment is not considered to be an accidental event. It's not a matter of oversight. It is a matter of, according to Freud, the idea that the unconscious within you simply caused you to forget. There was something in that previous week, it could be argued, that you simply didn't want to talk about, or you were afraid you might end up getting forced into talking about. And so that becomes a revealing. Everything is essentially a source of information for you, for your potential disorder, for the psychoanalyst as he's trying to analyze it. There is an interesting side effect that occurs here, and that is or may occur, and that is what's called transference. And the reason that happens goes right back into the heart of psychoanalysis, and that is basically what you're dealing with is emotions in this situation. One of the things that may happen is that the therapist, the psychoanalyst, will find that in fact his patients move in one of two directions. Either they literally fall in love with the psychoanalyst, or they come to hate them. And essentially what's happening is, according to psychoanalytic interpretation, is that the therapist comes to play a substitute role for whoever in the patient's life is the actual source of the difficulty. And so to the extent that you choose a psychoanalyst, it would be argued in this mode that essentially you tend to choose a psychoanalyst who shares or summarily does not share some of the features of the person in your life who's giving you the greatest difficulties. And in that sense, transference then is a revealing instance, a revealing episode, I guess I should say, in psychoanalysis. It would, of course, be ethically all sorts of wrong to respond at that level. That is, somebody's come to you for professional help as a psychoanalyst. There are all sorts of psychological encoded ethics to prevent you from responding, reciprocating with the love expressed by your patient by falling in love with them. That's a no-no. But for several reasons. First of all, there's a huge power difference between the therapist and the person seeking help in any kind of a social interaction like that. But then also, that transference really, if you back off and look at it, is a reflection of the whole reason that person may have come in to see you to begin with. So the fact that they fall in love with you is really only acknowledging the nature of the problem they've got and what similarities you share as therapists with the person who's causing that person difficulty. So transference is one of those very awkward things that in some ways you almost hope will happen, because it's instructive of what the nature of the underlying problem is that we're dealing with in that psychoanalytic tradition. Now, we can critique it in a number of different ways. It's time-consuming, it's expensive as a form of therapy. None has been ever developed that is more expensive psychologically. It may emphasize the past too much at the expense of solving current problems, although the argument, as I've been developing it, is that the past becomes dictator of the present. There is, in that theory, some would argue, too much sex, too much aggression. Those were the two primary drives that Freud focused on in psychoanalysis. And there is a lot of what is called unverified symbolism. I mean, it's one thing to talk about the symbolic meaning of a language, of a dream. It's quite another thing to demonstrate it in the lab, experimentally, operationalize it in any given way. And perhaps the most fundamental criticism is simply the questioning the lack of experimental evidence for what Freud developed. That theory now is much on the out. There are fewer and fewer psychoanalysts practicing as pure psychoanalysts, simply reflecting the fact that the field has really moved beyond it in ways that we'll describe here. One of the types of therapies that has taken hold, much more so nowadays, is what are called the humanistic or existentialist therapies regarding personality disorders. So whereas psychoanalysis is the oldest theory and therapy that has been markedly modified down through the years, it is now modified to make it less time-consuming, less expensive, and to address current problems much more directly. A typical therapeutic session may last as few as 10 or 12 sessions, start to finish in modern time. So whereas psychoanalysis really emphasizes the problem and the therapist directing what's going on in a given situation, biological urges and the events of the past, humanistic existentialist therapy as a counter-argument essentially emphasizes the immediate social influences in somebody's world. The emphasis is on growing from who you now are toward what you wish to become. So future growth is a major source of emphasis. You will hear words like actualization of human potentialities reflecting talked about. That's a mouthful. We'll come to define that a little more precisely here a little bit later. But essentially it's keyed on self-awareness. The assumption being that that's a key to growth and actualization, or the achievement of human potentiality, which is basically what we're talking about there. The therapy tends to emphasize insight into present experiences and how to interpret them most rationally. Takes a number of different forms. One of the most popular in this group would be what is called client-centered therapy, as originally proposed and developed by Carl Rogers. It basically emphasizes the client, hence the name, client-centered therapy. And it's a relatively non-directive therapy. That is, the therapist is not there to command you do this, you do that, but rather essentially what the therapist is trying to do in client-centered therapy is to develop what is called an empathic relationship. Empathic. It does not push the client in and of itself. That is, the role of a Rogerian, a client-centered Rogerian, is not to push you in one direction or another. That's really up to you. Which direction do you wish to move? But the therapist, him or herself, is going to be warm and accepting, and really does try to help the patient solve their own problems. And so the basic assumptions on which this form of therapy is developed or based are, first of all, the idea of the assumption of what is called constructive alteration of his or her personality. The underlying assumption on which this is based is the idea that you do have the potential for constructively altering who you are and how you interact with your friends and neighbors and cohorts. And the other underlying fundamental assumption here is the idea that that alteration will occur if the client perceives him or herself as unconditionally acceptable to the therapist. That is, what the therapist does in that situation is to project a non-judgmental view of whatever you're introducing to a given situation. You're simply accepted at face value. There's nothing beyond that in terms of the therapy. You know, you'll never hear a Rogerian going, oh, you should not have done that. That's judgmental. That's directive in terms of what to do, what not to do. That does not take part in client-centered therapy. So essentially the elements here are rather specific. One of them is simply what is called unconditional positive regard on the part of the therapist. That is, you are simply viewed unconditionally in a positive form. Nothing is done other than to reinforce the strengths that you present to the therapist in a given situation, and that's based, among other things, on acceptance. There's no disapproving, no negative evaluation of anything you relate in a given situation. The client should express true feelings. That's what this form of therapy is moving toward, is trying to get the client to feel comfortable giving vent to anything that he or she is carrying around internally and wishes to express in the situation. What the therapist then is really moving toward, in that phrase that I used earlier, is essentially the idea of empathic understanding. That is, the psychotherapist, in this case, the Rogerian, the client-centered therapist, can identify with the patient, the client, I should say, and can understand. That is, comes to understand him or her on a one-to-one basis in such a way that the warmth of the therapist that's being offered is perceived and is encouraging toward the client. That is, the client feels comfortable describing in considerable detail the difficulties that have driven him or her to seek various kinds of help. And the net result is that what the therapist is moving toward is an established sense of what is called congruence. And by that, what I mean is that the client comes to understand the therapist is with me. That is, he or she is in my head, understands what I'm saying, understands the perspective that I'm representing in terms of why I'm saying what I'm saying about my mother, my father, anything else. And that's essentially the basis for the exchange between the therapist and the client in this situation. So the therapist is essentially non-judgmental. The intent is strictly to encourage the patient to develop a sense of warmth and understanding that you can talk about whatever you want to talk about in this situation and develop that feeling of comfort on the part of the client. There are some criticisms that can be registered against this. That is, you can critique it constructively, and essentially it comes back to the fundamental assumptions that I originally stated there, and that is that the fundamental question about this therapy is essentially, do all people actually have the potential for growth? It may be essentially that you've reached the limits of your ability to interact with people in terms of the particular set of rules that you've developed for yourself. In some sense, they've been reinforced. They've worked for you. They've gotten you as far as they have. And the question then is, do people have the potential to grow from what they are toward what they'd like to be in a given situation? And the other question, equally researchable, is essentially, will unconditional positive regard release that potential? The fact that you're interacting with a therapist, the legitimate question that's involved there is, does the unconditional positive regard, the non-judgmental approach that therapist takes toward anything you want to say, is that really the basis on which to unlock the potential that you may or may not have in a given situation? Other therapies are also in this general caliber, or general approach, I should say. I'll list them, but I'm not going to actually talk about them simply because time is limited, but we have at least mentioned a couple of these. One of them would be Gestalt therapy as a general class of types of therapies. Another one is transactional analysis that you probably heard about, and that is the work of Eric Burns, very popular 20 years or so ago, even 30 in terms of books about the topic. Another one that you've probably heard about is rational emotive therapy. In fact, we've talked about it here. Albert Ellis's version of what's going on in the ABC model of behavioral interaction that may occur. And more recently, reality therapy of Glasser, that therapy actually became the fundamental therapy for basis for cognitive therapies, which we'll get to talk about just a little bit here at the end if I rush enough. But in essence, another broad class of behavioral therapies or therapies that we can talk about are the social learning or behavioral therapies, which is yet another approach to the helping of people with personality difficulties, quite different from the assumptions and practice of psychoanalysis, and equally different from the therapies we've just been looking at. The social learning and behavioral therapies are operating on a very simple assumption. They're a far distance from psychoanalysis or self-centered therapies, client-centered therapies, both in their assumptions and in their procedures. And they adopt a purely psychological model. They simply view the idea, treat the symptom, you solve the problem. It's the symptom that brought people in, not unconscious urges. There is, after all, a fundamental irony in the idea that somehow the things that are unconscious in you are what drive you into to seek therapy. And so the behavioral therapists go the other direction. They simply assume it's the symptoms that drove you in, and that's what we'll work on fixing or altering. So the basic assumptions here are fundamentally the idea that one is the idea that abnormal behavior follows the principles of learning, okay? Secondly, the individual's environment contains the major variables that are of importance in controlling your behavior in a given situation. And thirdly, behavior is largely determined by the reinforcements to which you respond. And you may respond differently to different forms of reinforcement, but in the learning model, it's the reinforcers that ultimately govern how you're going to behave in a given situation. And in this case, then, the treatment essentially uses the principles of learning. And the emphasis is going to be on present events, the here and now, and how to modify that. And it reduces essentially the importance of your personal history. They're arguing, theoretically at least, that how you got to where you now are is not so important as what we're going to do to shape the kind of behaviors that you really wish to exhibit. How are we going to shape your world in such a way that it becomes self-maintaining? Major successes would include things like treatment of phobias, essentially all neurotic examples of anxiety-based disorders are very effectively treated by this kind of therapy, I should say, and to a lesser extent, even psychotic disorders can be dealt with here. And I want to take a sample of a couple of these to show you essentially how they work. One of the classic examples here is to utilize essentially what is called systematic desensitization, which is essentially a hands-on personal use of what is called counter-conditioning. It was originally proposed by Joseph Volpe way back in 1958, and he noted basically that it's hard to be happy and sad at the same time. Essentially, it's hard to be relaxed and anxious at the same time. And he uses this, what is called reciprocal inhibition, as the basis for desensitization. That's the fundamental observation that he used and how he's going to convert it into helping people modify their lives. So he assumes basically the presence of anxiety under this kind of an assumption, and essentially the major cause of avoiding an otherwise neutral or positive goal is the anxiety that you have in your own head about the causes of it. So essentially what we do is to teach the client to avoid the anxiety arousal by relaxing. That's fundamentally what systematic desensitization is about. So in this element, the very first thing we get the patient to do is, let's suppose you've got a difficulty with snakes. You just don't like snakes, and you're unnerved by it enough that you decide, okay, I'm going to seek help. This is irrational. So the first element of this, basically the first step in this therapy, is get you to list all the different situations in which you have difficulties with snakes. So you jump right into the first, and that is, there's no way I could touch a snake. That would be, I could not do that. There's no way. Too anxious evoking, too anxiety evoking for me. I don't like to think about snakes. That makes me creepy crawly. I don't like to see snakes. That's the least appealing thing I would want to look at in a zoo. And even talking about it really makes me jumpy. So we might list 100 different situations here. The key, in some ways, is the second element, and second and third. The second element is that what you're now asked to do is to rank order. after we may have spent a day or two talking about all the different things about snakes that you don't like, that raise your anxiety, now what we're going to do is ask you to rank order those. And so for this particular patient, I'm only going to use the 4 symptoms. But for this person, if those were the 4 things that drove him in to seek help, one of the first things he might do is to say, okay, for me, thinking about snakes it makes me a little bit jumpy, but it's not as bad as some of the others I can mention here. And in fact, number 2 on my list is having to talk about snakes. That I also don't particularly like. And that's a little more anxiety provoking in my case. Seeing a snake is even more anxiety provoking. And finally then, touching a snake is just right at the top of the list. That would evoke so much anxiety in me, Doc, I can't just describe it for you. So first of all, we've listed the symptoms, then we've rank ordered them. Now we start the therapeutic portion of it, and that is what you're trained in, is what is called deep muscle relaxation. That is, you are given training in therapy over a couple of hours, essentially practice intensing various kind of muscle groups and then learning to relax them. That is, what kind of response do you have? If you think about curling your toes so tightly that the top of your feet arch upward in your shoes, and the desire there is to keep the pressure on in that situation, in this form of therapy. You're tensing yourself, and then most importantly, you're feeling what you have to tell yourself to get your foot to relax in that situation. That's deep muscle relaxation. So you'll be given practice in tensing all sorts of different elements of muscle in groups of muscles in your body, and then given practice in giving yourself permission to actually release the tension in that situation. And finally then, we move into desensitization, and that looks like the following. So what you're going to be asked to do in a given situation in desensitization is to envision, first of all, the number 1 thing on your list. We're going to start with the thing that is least anxiety provoking for you and encourage you to go through and practice relaxing. So we'll have you on the couch, and we are essentially, with help, verbal help, going to be encouraging you, okay, what I'd like you to do at this point is to think of the least anxiety provoking thing on your list here. And let's see, Alvin, and you walk down through the list, and in your case it was essentially thinking about snakes. So what I'd like you to do is to practice lying there thinking about snakes for a minute here. Not that we're trying to make you anxious, but rather that we're trying to get you to be able to think about snakes without feeling the anxieties that you've talked about before. And if you do begin to feel those anxieties encroaching on you, what you want to do is to jump directly into the deep muscle relaxation activity that we gave you practice on last time. And so if you start thinking about snakes and you begin to feel growing anxiety, get it out of your head. Think about a baseball game or whatever is non-anxiety provoking for you, fun, and practice the deep muscle relaxation. And as you can see, what you're engaged in there is essentially counter conditioning. What you're doing is walking them through the therapy in such a way that we start in their own self-generated list with the least anxiety provoking and tie to that experience in relaxing muscles, deep muscle relaxation. So the systematic desensitization is what's going on there. You're systematically going through the anxiety-evoking stimuli in increasing order of anxiety potential and tying it to the relaxation response. So we work with the thinking about it. Once we've got that under control, so you can now lie there comfortably and think about it, now what we're going to do is move into your number 2 issue, which is talking about it. And so let me talk about this, and if at any point I make you too anxious, there might be a cue labeled. For instance, what I'd like you to do is raise your finger when you're ready to talk about snakes, and I'll move the topic to that level. If it gets too anxiety evoking for you, I want you to go back into deep muscle relaxation, and that will of course cause your finger to fall. If your finger drops, that will be my cue to change the subject, get to something else because it's causing anxieties for you. And so we can work out an exchange on this basis where we work through each of the different anxieties, self-declared anxiety-provoking situations there. And in essence, what we can do then we're utilizing classical conditioning to treat things like phobias, general anxieties, and what's involved there is essentially what you're praying for here, praying for is the wrong word, what you're working toward here is the idea that the patient, you won't have to sit there for hours going through each of the elements in the hierarchy. What you're doing is teaching the skill of relaxation. So as you get through 2 or 3, maybe the first 5 symptoms, if there are that many, the patient ultimately is assumed to be capable of generalizing the technique that you've taught from the situations that you started with which were the least anxiety provoking, and apply that in the further down the hierarchy. So you don't really have to literally go through the entire rank ordered list, but rather rely on the fact that you teach the patient a skill and rely on him or her to apply it more generally in the situation that you have in a given problem here. I think there was one other thing that I wanted to talk about. I was going to introduce the idea that one investigator was able to introduce that even demonstrate that even progressing through 25 to perhaps as much as half of the overall hierarchy is enough to teach the skills, which can then be applied more generally by the person involved in the therapy. One of my favorite forms of therapy here is essentially what I also wanted to fold in here, and that is the implosive therapy. This is in some ways is my favorite therapy, because in this case what you do is exactly the opposite of what you did in the therapy that we were describing before. That is, now what we're doing is assuming that anxiety is the major source of the difficulty that you experience, and if the client escapes a given stimulus situation, no extinction occurs. And so the story that is often involved here is the idea that a patient comes in with the idea that he keeps throwing Kleenex out the window of the bus, and the therapist rides along with him and asks, well, why are you throwing the Kleenex out the window of the bus? And he said, it keeps the elephants away. And the therapist, of course, rose right up and said, well, there are no elephants here. And the patient looks right at him and said, see, it works. And so the difficulty that you've got in this kind of a situation is essentially the need to take the extant behaviors and offer a solution for them. And if anxieties are the source of the difficulty, what we really come down to is that with implosive therapy, what you do is to build up in the patient the largest intense reaction that you can possibly get and hold it there for an hour. You spend an hour talking about all the nasty things that may happen to whatever is their feared object. And the goal is that at the end of the hour, you point out, well, now, wait a minute. Let's check. Other than the big bands of sweat around your armpits, there's no other adverse effect that's occurred here, is there? So we plunge you into anxiety, pointing out as we're pulling you out of it that, well, wait a minute, there's been no ill effect. And we'll pick up on that next time in critiquing these forms of therapy.